Good morning, everyone. My name is Shivani, and I'm an occupational therapy student. My honors thesis examines the feasibility and usefulness of an outcome measure called RAS Recovery Assessment Scale Domains and Stages, also known as RAS-DS. In my presentation today, I'll be first sharing with you the background of our study, the methods we've undertaken, as well as the results and what they mean for our study. So let me first start off with, what is RAS-DS? RAS-DS is a self-rated outcome measure of personal recovery that is used with people with mental illnesses. So, what is personal recovery? Over here is a very common definition that's used among practitioners and researchers in the mental health field. However, what it essentially means in more layman terms is that personal recovery focuses on the individualistic nature of each person's recovery journey and focuses on what is important and meaningful to the person in living a life that is satisfying, hopeful, and contributing. Now, most of us would be more familiar with recovery in the sense of cure or reduction of symptoms or illnesses. Traditionally, mental health practices have also focused on a similar medical model. However, in recent years, there has been a rise in the notion of personal recovery. To support personal recovery amongst individuals, mental health services have been undergoing system reforms to ensure that their practice is recovery-oriented. However, one of the changes that have yet to be made is inclusion of recovery measures within national or service-mandated routine outcome measures. The current routine outcome measures that workers have to use are symptom-focused and do not align with recovery principles. In order to reorient services towards recovery-oriented practice, it is crucial that we include recovery measures within routine outcome measurement. RAS-DS is a potential candidate for this, as beyond its ability to measure recovery, its main aim is also to be used as a tool to guide and promote recovery-oriented practice. So what do we need to consider for routine outcome measures? A tool that is appropriate for routine outcome measurement should not just be psychometrically sound, but also feasible and useful in practice to clients and workers. The feasibility and usefulness of a tool is important to assess, as factors such as time taken, relevance and usefulness of a tool in practice are often cited as reasons for routine outcome measures not being used in practice. So, what do we know about the RAS-DS? RAS-DS has demonstrated sound psychometrics and can be considered a valid and reliable tool that is sensitive to change. However, we've yet to conduct a more in-depth study on the feasibility and usefulness of RAS-DS. In an earlier study that was conducted on the feasibility of RAS-DS, the research team briefly studied time taken, ease of completion, as well as the usefulness of it. Although these are all important to consider, there are other aspects of feasibility that have not been covered. A more comprehensive assessment of feasibility and the usefulness of RAS-DS will contribute towards a stronger justification of its routine use in practice. Therefore, the aim of our study is to examine the feasibility and usefulness of RAS-DS in everyday practice from the perspectives of mental health workers. So our study adopted a survey design with mixed methods, collecting both quantitative and qualitative data. To participate in the study, participants had to be currently or previously using the RAS-DS in their practice. This was important to ensure that we collected rich data on the feasibility and use of RAS-DS from people who had experience using it in their practice. To recruit participants for our survey, we sent out invitation emails to workers who had previously approached the RAS-DS research team to inquire about or seek permission to use it in their practice. This also included workers from other countries. To maximize our response rates, we also encouraged participants to forward the email to colleagues they knew were using or have used RAS-DS. So the survey we designed had a mixture of quantitative and qualitative items to explore the feasibility and usefulness of RAS-DS. To investigate feasibility, we developed a scale based on the overarching framework of feasibility proposed by Andrews, Peters, and Thiessen in 1994. We also added, as there were inconsistencies and differences in what was considered part of feasibility and what was not in the literature, we decided to also include additional but also complementary items within Andrews' framework. So the framework proposed that a feasible measure is one that is practical acceptable, and applicable to workers and clients. The end product was a 14-item scale that included statements relating to each of the 3 domains of feasibility. And participants were asked to rate each item on a 5-point Likert scale from strongly disagree to strongly agree. They're also given the opportunity to comment on and explain their ratings. Now let's have a look at the different domains of feasibility. So first up, we have practicality. Practicality considers the burden imposed on clients and staff in using the tool. So we look at the length of a tool, the time taken to complete it, training requirements, as well as the ease of scoring and interpreting. Acceptability refers to how easy it is for clients to understand the purpose of the tool, the wording used, and also consider if there's flexibility in how clients complete the tool, whether it's on their own or with the staff, depending on their preference. Lastly, we look at applicability. Applicability considers how meaningful and important the tool is to clients. It also looks at the value of an outcome measure in influencing practice. Does it promote discussions between workers and clients? Does it also contribute towards intervention planning and overall client care? So lastly, we also have the usefulness section of the survey. We asked participants to rate the overall usefulness of RAS-DS, comment on what they felt were the most useful and least useful aspects of RAS-DS, as well as how it was helpful in promoting recovery-oriented practice for them. So for data analysis, quantitative data were analyzed by calculating frequencies and percentages for responses to the feasibility items and usefulness rating. To give us a clearer understanding of feasibility as a whole, we also calculated a total feasibility score, which is an average of the ratings for all the items. We also calculated similar total scores for each feasibility domain. Qualitative comments were analyzed thematically by using a method called constant comparative analysis. This allowed us to identify common themes that were present across participant responses. So let's have a look at our results. So overall, 58 mental health workers participated in our study. Participants were mostly based in Australia and worked in community settings with adult clients. Overall, the data we collected suggests that RAS-DS is a feasible and useful measure in practice. Let's first have a look at the participant ratings of feasibility. The median of the total feasibility score is 3.93 over 5, which would indicate a feasible measure. Looking across the domains, applicability and acceptability were rated quite highly. However, it was the scores of practicality that weighed down the overall median score for total feasibility. Overall, the items that were most highly related to the applicability of RAS-DS. Over 90% of participants agreed that the areas covered within RAS-DS were meaningful, as well as that RAS-DS is able to promote discussion. Within practicality, the items that were rated lowest related to the length of and the number of items included in the RAS-DS. Participants who felt that it was too long said that they would prefer using a shorter recovery scale. What was interesting though was, on the other hand, participants who felt that the length was appropriate said that the length was necessary to explore recovery. In comparison to the length, it was the benefits of using RAS-DS that was much more important. The length of a tool is commonly cited as a deterrent for workers not using outcome measures routinely in practice. And therefore, it might be worthy considering developing a shorter version of RAS-DS. However, considering the different perspectives of participants, it's also important to acknowledge that although a shorter version is more practical and easier to implement, reducing the length might compromise on the usefulness of the tool in practice. As we know that both feasibility and usefulness play a role in influencing the uptake of measures, further exploration may be required to determine how to strike a balance between these two factors. So next we look at the overall usefulness of RAS-DS. About 2/3 of participants reported that RAS-DS was quite useful in their practice. Similarly, about 85% of participants felt that RAS-DS was helpful in promoting recovery-oriented practice. As for the most useful aspects of RAS-DS, these were the top 5 themes reported by participants. What is interesting and what stands out in these results is how participants have valued using the RAS-DS to guide their practice with clients beyond its role as an outcome measure. The aspects highlighted by participants are also examples of how the RAS-DS can be aligned with and supports recovery-oriented practice amongst workers. Participants also, looking at the least useful aspects of RAS-DS, participants most commonly cited that RAS-DS was too long, that the RAS-DS was too long. And this was similar to what was highlighted within the feasibility responses. Another issue that was raised by participants was that the RAS-DS results were dependent on the client's insight of their diagnosis, how much they wanted to disclose, as well as their mental state on that day. These are all valid statements, as it is expected that factors such as client's mental state will impact their results. However, self-rated measures such as RAS-DS emphasize on gaining an understanding of client perspectives. If workers do not agree with these ratings or feel that is not representative based on their understanding of the client or what they have previously discussed with the client, a way to approach it could be by engaging client in conversations about why they may have given a certain rating once they've completed it. This concludes the results we've collected. One of the limitations of the study is the use of a non-random sampling method to recruit participants who have used the RAS-DS. As it is more likely that participants who were using RAS-DS found value in it, it's possible that our data may have been positively skewed. Additionally, a large proportion of our sample were workers working in the community with adults. This restricted our ability to investigate how feasibility and usefulness of RAS-DS may differ in different contexts and therefore get a more complete and deeper understanding of feasibility and usefulness of RAS-DS. Overall, the results indicate that RAS-DS is a tool that is feasible and useful in practice, and appraise it as a tool that can be used to guide workers in their practice beyond just measuring outcomes. It also extends the evidence towards supporting the routine use of RAS-DS by mental health workers to monitor recovery and promote recovery-oriented practice.